I would like to talk about Peutz-Jeghers syndrome. Although Peutz-Jeghers syndrome is not a very common disease, the treatment strategy has changed dramatically over the past decade or so due to advances in endoscopy. I chose this topic because I think that there may be patients who are being treated for this disease who have not yet undergone much endoscopic treatment, and I thought it might be a good opportunity to make them aware of endoscopic treatment. This presentation will cover the following three topics. First, the characteristics of the disease of Peutz-Jeghers syndrome will be explained. Next, I will introduce the contents of the guidelines for the treatment of Peutz-Jeghers syndrome, which were published for the first time in Japan in 2020. Finally, I will introduce the endoscopic pre-treatment performed at Jichi Medical University Hospital. The first is an overview of Peutz-Jeghers syndrome. As for the origin of the name Peutz-Jeghers syndrome, Peutz is taken from Doctor Peutz of the Netherlands, who first reported the disease in 1921. Jeghers was taken from Doctor Jeghers of the United States, who first defined the disease as a syndrome in 1949. It is estimated that there is one patient in every 50,000 to 200,000 people. The three main features of Peutz-Jeghers syndrome include the following: hamartomatous purposes, mucocutaneous pigmentation, autosomal dominant inheritance. Polyps with excessive growth of benign cells are called hamartomatous polyps. Hamartomatous pulposis means that these are found in large number in the stomach, small bowel, and large bowel. Hamartomatous polyps are benign polyps, but they grow in size over time. Enlarged polyps block the bowel and cause abdominal pain. If the polyp completely blocks the intestine pulled by the large polyp will be pulled into the intestine downstream and will not return, resulting in intussusception, which may require emergency surgery. Mucocutaneous pigmentations are dark, mole-like spots of a few millimeters in size that are characterized by multiple occurrences on the lips, tip of fingers, or inside of the mouth, as shown in the photo. They do not cause any particular problematic symptoms, but they are a characteristic change that often triggers the diagnosis of the disease. One of the ways a genetic trait or a genetic condition can be inherited. In autosomal dominant inheritance, a genetic condition occurs when a variant is present in only one allele of a given gene. For example, in the case of this figure, if a child inherits the gene from the father with Peutz-Jeghers syndrome, the child will also develop the same Peutz-Jeghers syndrome. In the case of Peutz-Jeghers syndrome, the STK11 gene, which is the causal gene, is located on the autosomal chromosome 19, so it takes the form of autosomal dominant inheritance. The STK11 gene is known as a cancer suppressor gene and is responsible for regulating the use of energy and cell division to prevent cells from using too much energy or dividing too rapidly. When this function is suppressed, energy is actively used in the cell and cell division becomes more active. But it is still unclear why this causes polyposis and pigmentations. Next, I will introduce the Japanese clinical guidelines for Peutz-Jeghers syndrome. In 2020, a group of experts in Japan published a guideline for the treatment of Peutz-Jeghers syndrome in children and adults. This is the first guideline for the treatment of Peutz-Jeghers syndrome in Japan. Based on this guideline, we will explain how to diagnose, examine, and treat patients with Peutz-Jeghers syndrome. An English version of this guideline was subsequently published in 2023. First, I will explain the diagnostic criteria presented in this guideline. Check for mucocutaneous pigmentation on the lips, mouth, fingertips, etc. If pigmentations are observed, an endoscopy is done to check for polyps in the digestive tract. If a polyp is found, one should be removed and examined under a microscope. If pathologically confirmed as a hamartomatous polyps characteristic of Peutz-Jeghers syndrome, after confirming that it is not a disease that causes polyps to form in other digestive tracts, Peutz-Jeghers syndrome can be diagnosed. In case of no pigmentation, in this case as well, if a polyp is found in the digestive tract by endoscopy and the resected polyp is pathologically confirmed to be a hamartomatous polyp characteristic of Peutz-Jeghers syndrome. Furthermore, if a close relative has a patient with Peutz-Jeghers syndrome, the diagnosis of Peutz-Jeghers syndrome can be made after excluding other diseases. Even if there is no family history of Peutz-Jeghers syndrome, if multiple polyps are pathologically determined to be hamartomatous polyps characteristic of Peutz-Jeghers syndrome, Peutz-Jeghers syndrome can be diagnosed after excluding other diseases. If neither criterion is met, Peutz-Jeghers syndrome can be diagnosed if genetic testing confirms a germline pathogenic variant in the STK11 gene. These clinical guidelines list 4 clinical questions: genetic testing, gastrointestinal testing and treatment, non-gastrointestinal testing, and treatment for pigmentations. I will also explain these. Clinical question 1. Is it recommended to perform genetic testing on patients who meet the diagnostic criteria for Peutz-Jeghers syndrome? We do not recommend genetic testing because it is not information that can be used as a reference for the patient treatment itself. Genetic testing will examine whether there is a pathogenic variant in the STK11 gene, that is, an abnormal sequence of the gene that causes the disease to develop. In other diseases, it is sometimes found that the intensity of symptoms differs depending on the site of the pathogenic variant. But in the case of Peutz-Jeghers syndrome, at present, polyps and pigmentation do not depend on the site of the pathogenic variant. There is nothing clear that the susceptibility to cancer changes. For this reason, there is not much merit in testing for the person who has been diagnosed with Peutz-Jeghers syndrome. However, in order to find out whether a relative has Peutz-Jeghers syndrome, it is useful to confirm the individual's pathogenic variant in advance. Clinical question 2. Is surveillance and treatment of gastrointestinal region recommended in Peutz-Jeghers syndrome? Surveillance for gastrointestinal region is recommended. First, hamartomatous polyps are reported to occur in 24% of patients with Peutz-Jeghers syndrome in the stomach, 24 to 27% in the large intestine, and 96% in the small intestine. These polyps can cause bleeding, infection, intestinal obstruction, and interception, so it is very important to check them beforehand. Regarding cancers of the gastrointestinal tract, it has been reported that 29% of patients with Peutz-Jeghers syndrome develop gastric cancer, 13% of small intestinal cancer, and 39% of colorectal cancer. surveillance is important for early detection of these cancers. Although we do not have enough data to strongly recommend when to start surveillance, since there are many patients who undergo the first surgery for intersusception in their teens, it is recommended that the first surveillance should be performed at around 8 years of age. For small children, capsule endoscopy or MRI is often selected as the surveillance method because it is minimally invasive and does not cause radiation exposure. After that, it is recommended to conduct surveillance every 1 to 3 years for those who have found polyps, but if no polyps are found, the next examination can be done around the age of 18. After that, surveillance every 1 to 3 years is recommended. Since the risk of cancer increases after the age of 50, surveillance every 1 to 2 years is recommended. Endoscopic treatment for polyps is also recommended because it can prevent intersusception. Small intestinal polyps are often the cause of intersusception, so treatment with a balloon-assisted endoscope, which can reach and treat small intestinal polyps, is recommended. Since the risk of developing intersusception increases when the size of the polyp exceeds 15 mm, it is recommended to give priority to treatment. Surveillance for extragastrointestinal regions is weakly recommended. It is reported that the risk of developing all cancers increases after the age of 40. It is also reported that more than half of patients develop cancer after the age of 60. However, the exact frequency and age of onset are not yet known. Cancer is more likely to be cured if it is detected early. Some surveillances involve radiation exposure, and there are disadvantages such as the risk of secondary cancer due to repeated radiation exposure from a young age. It is necessary to decide what kind of surveillance should be conducted and at what interval, considering the balance between advantages and disadvantages. Here are surveillance methods that seem to be balanced at this point. Breast cancer surveillance by breast MRI, ultrasound, mammography, and self-examination is recommended at 1-year intervals beginning at the age of 25 years. For ovarian cancer, surveillance by MRI and ultrasound is recommended at 1-year intervals after the age of 18 to 55 years. Surveillance by tumor markers is not recommended. For cervical cancer, cytological examination by cervical smear method is recommended every 1 to 3 years from 18 to 25 years old. Because patients with Peutz-Jeghers syndrome may develop a special type of cancer that is difficult to distinguish from benign, minimally deviation adenocarcinoma from a young age, ultrasound and MRI examination should be considered. Surveillance by internal examination and ultrasound every year is recommended after the age of 18 to 25 for endometrial cancer. Surveillance by palpation at 1-year intervals from birth to adulthood is recommended for testicular tumor. Ultrasound examination is recommended when abnormalities are detected by palpation or when gynecomastia is detected. It is reported that approximately 10% of patients with Peutz-Jeghers syndrome has large cell calcifying cell-to-cell tumors. Although there are no data to recommend definite surveillance for lung cancer, at least smoking cessation is recommended. For pancreatic cancer, surveillance using MRCP and endoscopic ultrasound is recommended at intervals of 1 to 2 years from the age of 30. It has not yet been sufficiently verified that the actual implementation of the above-mentioned surveillance led to the early detection of cancer. Please understand that further investigation is required. The recommended methods of organ-specific surveillance are listed in the table. Sorry, it is so tiny and also displayed sideways. You can download the PDF link on the YouTube overview section. Treatment for cosmetic effects on pigmentation is weakly recommended, although no studies have yet been conducted with large-scale validation. Laser treatment has been reported to be effective in either method. Finally, I would like to talk about the actual results of polyp treatment by endoscopy at Jichi Medical University. As I mentioned earlier, balloon-assisted endoscopy is used for endoscopic treatment of small intestinal polyps. A balloon-assisted endoscope is an endoscope with a hose-like overtube with a balloon. Double balloon endoscopes will also have a balloon attached to the tip of the endoscope, and single balloon endoscopes without an endoscopic balloon are used. Explain the principle of a balloon-assisted endoscope. Even if an endoscope is inserted into an unfixed intestine, it will deflect and cannot be advanced. A balloon endoscope can be advanced without deflection by creating support with an overtube fixed with a balloon. This is shown in the video. The balloon at the end of the overtube holds the endoscope in place, allowing operations performed at the hand to be transmitted directly to the tip of the endoscope. Here is a video of the endoscopic resection of small intestinal polyps using a double balloon endoscope. After confirming the shape and the stalk of the polyp, adrenaline mixed saline was injected into the stalk of the polyps to prevent bleeding. A snare was tied around it, and after tightening it, a high-frequency electric current was applied to cut it out. The resected stump was often clipped in to prevent bleeding. If the resected polyp is to be examined under a microscope, it must be retrieved. A schematic illustration of endoscopic resection is shown. A wire rod called a snare is placed over the stalk of the polyp. Clips are applied to the resected stump to prevent bleeding. However, even when clipped sufficiently, bleeding after resection can be a problem. If the polyps are clustered in a small area, the snare may grab the surrounding polyps when it is applied. There is a risk of entrapment of the intestinal wall and a perforation of the intestine. In addition, snaring itself may be difficult due to poor maneuverability in case with adhesions caused by laparotomy or in the deep small intestine. What is an easier and safer method? As mentioned earlier, small intestine polyps in Peutz-Jeghers syndrome are benign hamartomatous polyps. However, large polyps may also become malignant. However, it is said that many small intestinal cancers are not caused by polyps themselves, replacing cancer. Therefore, I thought that if the polyps were benign, it might not be necessary to correct all of the resected polyps. If so, it may not even be necessary to remove it. Clips are applied to the stump after endoscopic resection to prevent bleeding. We wondered if it might be possible to treat simply by clipping. The treatment that was conceived in this way is the ischemic polypectomy. We thought that if we put a clip on the stalk of the polyp, the blood flow would be interrupted and the polyps would drop out spontaneously. 5 days after the clip was placed on the polyp stalk, the polyp was observed again endoscopically, and the polyp had been clipped and had changed into a string like this. For polyps with large stalks that are difficult to clip or polyps without stalks, we also performed the hemostatic treatment by tightening a string called a detachable snare. This one also confirmed that the polyp was necrotic when observed 3 days after the detachable snare was applied in the same way. Here is a video of actually ischemic polypectomy. There is a polyp here, but it's difficult to observe, so we observe it underwater so that the polyps float and the stalk can be seen clearly. One clip is first applied to the stalk. If the blood flow is not sufficiently blocked, a second clip is placed with a slight change in clip direction. The treatment is complete when the polyp is observed to turn purple in color. We would like to introduce the results of treatment at Jichi Medical University Hospital. We performed double barrel endoscopy for Peutz-Jeghers syndrome on 67 patients until April 1, 2020. The average age at the time of the first barrel endoscopy was 30.8 years old. Of these patients, 79% had undergone laparotomy to treat small bowel polyps before the first double barrel endoscopy was performed. In total, we performed 531 double barrel endoscopies. The average number of double barrel endoscopies per patient was 7.9. It is a little small and hard to see, but the number of double barrel endoscopies performed per age is written in the right blue bar. The number of treated small intestinal polyps was 644 resected, 1,957 clipped, and 257 detachable snares, for a total of 2,858. The average number of treated polyps per patient was 42.7. Of the treated polyps with ischemic polypectomy, 3.9% required additional procedures later. Polyp treatment by double barrel endoscopy is basically performed in hospital, even after treating the polyps in one hospitalization. New polyps often form, so repeated treatments are necessary. However, the number of treated polyps 15 mm or larger, which may cause intussusception, tended to decrease with each hospitalization. The size of the largest polyp treated in each hospitalization also tended to decrease with each hospitalization. These findings suggest that polyp treatment by double barrel endoscopy may reduce the risk of intussusception. In fact, there was only one case in which intussusception due to an enlarged polyp after starting endoscopic treatment required surgery, and surgery may have been avoided in other patients. I will explain the adverse events caused by double barrel endoscopy. 6 cases of after-treatment bleeding, 8 cases of acute pancreatitis, 2 cases of perforation, and 1 case of intussusception caused by the treated polyp, a total of 17 cases, 3.2%, were recognized. This was a similar rate to previously reported double balloon endoscopy adverse events rate. All cases of acute pancreatitis were mild and improved quickly with intravenous treatment. Post-bleeding, perforation, and intersuspension, which often require additional endoscopic procedures or surgery, occurred only in patients undergoing endoscopic resection and were not observed in patients undergoing ischemic peripectomy. Summary: endoscopic treatment of small intestinal polyps in Peutz-Jeghers syndrome can be performed safely and with repeated procedures can be expected to eliminate the need for laparotomy. However, some patients who have undergone laparotomy prior to endoscopic treatment may have difficulty inserting the endoscope due to postoperative adhesions. For these reasons, we believe that endoscopic treatment should be preferred over surgery. Thank you for your attention.